Hi, everyone. Welcome back to part 2 of our conversation with Dr. Deb Houry of the CDC and Dr. John Draper of the National Suicide Prevention Lifeline and Vibrant Emotional Health. What I love about the messaging that you're both giving to people is that sometimes when people who are suicidal or in crisis, they may report they're feeling hopeless, and it's easy for us to borrow that, to also feel that way, feel helpless, feel frightened. And what I'm hearing is that we actually can play a really active role and that we're not in fact helpless. We already have the skills if we do the things that you're talking about. Just checking in on someone is in fact protective. So I appreciate that facility that we can all have in playing a really important role in protecting each other as well as ourselves.
There was actually just a survey that was done, American Foundation of Suicide Prevention. I think perhaps EDC was also involved, or National Action Alliance, but they were asking questions of the public about, how what their thoughts were about suicide, how it was preventable, and if there's anything they thought they could do about it. And many of them, most people thought, yeah, suicide is preventable. And most people thought that they would want to do something about it if somebody in their lives was suicidal. The problem is that most of them said, I don't really know what to do. I don't feel confident about what to do. And I don't think we've done a very good job, Lisa, really communicating to people that you don't have to fix it. You really don't. And you don't have to be an expert. In fact, there are things that I can say as a loving, caring person to somebody in my life that a therapist can never say, that are life-saving words. Things like, you'll never have to go through this alone. I'm going to always be there for you. And I love you. You mean so much to me. Those are probably the most therapeutic words anybody could hear who's feeling lost and alone.
Really excellent point. We've been in this moment, as I mentioned, that is 6 months long. And during that time, Mother Earth has not ceased her activity. And we've had hurricanes, we've had wildfires. The planet doesn't care that a pandemic is going on. And John, I want to build on what you were talking about earlier and ask you to comment on how the pandemic and other disasters that are going on, like the wildfires on the West Coast, have highlighted the need for disaster mental health.
Yeah, for eons, when FEMA was established initially, and American Red Cross, the focus post-disasters has really been on basic needs. How is it that we can get people shelter and food and communications? Those are all absolutely essential and undeniable and very tangible. What it took us years to actually begin accounting for is the emotional impact of what it was like to be going through these moments where you've perhaps lost everything, or lost a sense of connection to your community or your loved ones or your home, and being gripped with a sudden fear of death or of losing everything. And these are things that are not just experienced by you, but by an entire community or communities. So this is a population mental health catastrophic event that occurs when disasters happen. And so having it, it's just because you're sharing it doesn't mean with others, doesn't mean it's not a problem. It means that many people are having the problem. So it takes a more community public approach to help build resilience. And there hasn't been a lot of talk publicly about that. And even in the media, while disaster mental health services have been around, and probably most prominently since 9/11, they started in the late 80s, in the 90s, so it's still a relatively new thing. As you know, Vibrant Emotional Health operates the SAMHSA-funded disaster distress helpline, which we thought was absolutely essential to be pushing out there during the pandemic, because we learned after Katrina hit, and there was, a multi-state disaster, and SAMHSA had just established through us the National Suicide Prevention Lifeline. We've got to get help to people who are feeling completely disenfranchised and lost and separated from their loved ones and community. Let's make sure that we get them not just help for basic needs, but also emotional needs. And so they said, well, what do we have? Well, give them the National Suicide Prevention Lifeline. But we immediately noted, wow, putting a suicide prevention lifeline out there during a catastrophic event that's affecting many people is kind of the wrong public health message. We need to kind of normalize the fact that there are normal reactions to abnormal events, which are feeling very distressed. And so we need a separate but related service to it. Our crisis centers are completely capable of managing these services. They just need to be marketed to people in a way that they say, oh, that's for me. And so the Disaster Distress Helpline was created years ago, or years later, by SAMHSA. In 2011 is when we launched it, with some of our crisis centers who've been trained to help people who feel displaced, lost, alone, or impacted by a disaster, even years afterwards. And so we've really been pushing the Disaster Distress Helpline out there, so people become more aware, not just of disaster and mental health, but also how to find it during these challenging times.
Yeah, absolutely. Deb, what are your thoughts on this?
So, I think even looking at it from a different angle, I think John had mentioned about not just focusing on the recovery period during a disaster, but really that whole length of time. So I think it's like, how do we do things differently? How do we learn from like this pandemic that can apply to the fires, that can apply to hurricanes? And so two things come to mind for me, and one is that holistic point of view, and that's, what's happening with adverse childhood experiences and substance use right now. We need to be thinking of those at the same time so we can prevent childhood trauma and prevent, a worsening substance use crisis in our country that, can impact suicidal ideation and suicidality. But also, as John was mentioning, like, you don't want to just put up the lifeline number. That's not just prevention in itself. What can we do differently with our interventions? So things like gatekeeper training. We're now looking at CDC. How can we do that online? For some of our peer support groups and interventions, how do we look for ways to do it, also online, or as John was talking about with some of the great work he's done, texting. What are different creative ways we can do? Because hopefully there won't be another pandemic like this, but I think we all know there'll be another disaster, another crisis. And so how can we really deliver these interventions better, more effectively, and in this new era we are in?
I love that, Deb. That's great.
Yeah. Thank you. And I wonder, just for clarity for folks who may be watching at home, we've used the expression adverse childhood experiences a few times, or events a few times. I'm wondering if you would help explain what that is.
Sure. So, it can be a number of things. At CDC, we really define it as if a child is experiencing physical, sexual, or emotional abuse or neglect, or if they experience substance use in the home, or they witnessed it, or violence in the home, including if a parent or a loved one is suicidal. Other childhood traumas also can fit into that, though, like an earthquake or a disaster can certainly be considered childhood trauma. And what is, I think, really important to know about these ACEs, or adverse childhood experiences, if you have this childhood trauma, it can make you more likely to have different chronic health conditions like high blood pressure. It can make you more likely to think about suicide or to overdose on drugs, but it's preventable. Some of the same things we're talking about today about building that resiliency and really that inner capacity helps really lessen some of the consequences from adverse childhood experiences.
Thank you for explaining what that means and what the relationship among all of these things are. I want to talk a bit about the myths that surround suicide and suicide prevention, which have not gone away. And I'm wondering, John, what are the most important myths about suicide that we need to dispel?
Well, right now, there's always myths, and the two that that are really top of mind right now, given the pandemic. One is there's people love to assign singular causes to suicide. They love to say, well, since, unemployment's going up, there's going to be a huge increase in suicide. But now there is a correlation between unemployment and suicide, but it's more complicated than that. It's always more than one thing. And I'll give you an example specifically related to that. At the beginning of this year, our employment was at record high. And so were our suicide rates, much higher than we'd seen them in decades. So there isn't a one-to-one relationship. There's a number of factors that we need to be thinking about. And I know when we think it's very complicated, we may also think, well, then how are we can't prevent it, because therefore the solutions must also be complicated. And that's also a myth. Maybe in some circumstances, it requires a lot more complications or more complicated approaches than we might have at our disposal. But many times, it is not that much more complicated than staying connected and being with someone and letting them know that they're valued. I mean, certainly there's some people who are in severe need of psychiatric help, and constant monitoring. But as I mentioned before, I think we've given the impression that the only way that people who are suicidal can be helped is if professionals help them. We say, if they're suicidal, call 911, which is really not the right thing to do most of the time. And if they're suicidal, they have to go see a therapist. Well, that would be ideal, but not always easy. Or they have to call the Lifeline. I think that's great. Absolutely. Call the Lifeline. But that's also not always practical. What we know is that most suicides are actually prevented, perhaps not by professionals, but by working or being with people who care about them, who are caring for them in the right way. That's kind of the best kept secret. For every one person who dies by suicide, there's another 280 people who think seriously about suicide but don't kill themselves. And I guarantee you, most of those 280 people did not go see a therapist. There was something that happened in those suicide prevention stories, and those stories need to be told so we understand, my gosh, it isn't always just seeing a therapist, or certainly not just calling 911, but things that people are doing with others and for others in their lives that are making a difference.
Any other thoughts about myth busting, Deb?
Yeah, so I think back to, my days in the ER, and I think this one really goes out to frontline providers, whether it's like police or EMS or those, even probably those working on crisis lines, people will think if somebody, attempted suicide, they're going to go on to die by suicide at some point. And only about 5 to 10% of people go on to die by suicide after an attempt. And so I think it's so critical that if somebody has attempted suicide or is thinking about suicide, to realize it's not inevitable, it's very preventable.
Mm-hmm. Mm-hmm. And that's a really great point. Something I've heard certainly in my lifetime, both personally and from other professionals, is, well, if somebody really wants to do it, if they really want to die by suicide, they're just going to do it. And there's not a whole lot that we can do. And what you're both pointing to is that is absolutely not the case at all.
Well, and it's also important to note, even that initial premise, if somebody really wants to do it, is questioned and questionable. What we have found is that, people absolutely can voice a very strong intent, and people can act on that very strong intent, unquestionably. But what we've also learned with just about everybody, and I've heard no exceptions to this point, that people who've said, absolutely want to kill myself, that in the end were ambivalent. What they were absolutely sure of is they wanted to end the pain. Absolutely sure. And they saw no other way, like a horse with blinders, of ending their pain. Now, if it meant ending their life to do that, that's what it meant. But that is not essentially what they want. And what we've learned is from just a host of people who survived suicide attempts, back to the point that Deb was making, there's been the overwhelming majority of people survived their suicide attempts, and many of them will tell you, oh my God, I really wanted to die. I really did. But now I'm so glad I'm alive. And actually, what I've heard from a number of people, that in the emergency departments, when their last breaths after killing themselves, or their last statements are, please save me. And talking with people who've jumped off of bridges and shouldn't have survived, but did, they said the first thing they thought of when they jumped was, oh my God, I don't want to die. And now look what I've done. And so there are people we'll never be able to interview as to what their final thought was before they died. But what we do know is that ambivalence at the very core is that we want to preserve our lives, but we don't want to live with this pain. So how do we deal with that?
Yeah, yeah. Anything to add on that, Deb?
I think, I'm still thinking about some of the patients I've seen, were literally after they had shot themselves, they would say, "Don't let me die," when I was in the emergency department caring for them. And John mentioned it earlier, but I think that's too why if somebody's ambivalent but thinking about it, safe storage of things like medications and firearms is so important, because some suicide attempts we know just happen with thinking about it, and then 5 to 10 minutes later it might be enacted. And so if you can reduce access to things like lethal means for people who are suicidal, that's really important.
Yeah, makes a lot of sense. And we're coming toward the end of our talk together, but before we end, I just wondered, any words of hope for folks who are listening today at home? What gives you hope? What might give other folks some hope? And maybe we'll start, Deb, with you.
So I have a kiddo. You can probably see the picture of her right next to me. So that gives me hope. I've always said I love the work I did in the emergency department, but now in CDC, just knowing the impact we can have on so many more lives rather than just the patient in front of me. And I want to, leave the world a better place for my middle schooler. And, I think when we look at the resilience of youth, I ask her all the time during this pandemic, how are you doing? Are you worried? It's amazing how resilient youth are, and how, she's surviving and actually even thriving, probably because we have a lot more time together now than we used to. And so I think really capturing some of that, just looking at, I don't think any of us wish we were in this pandemic, but what can we learn during this that builds our own resilience? And John was talking about, like, how do you, intellectual stimulation. I've been doing, more reading and looking at book authors online. So how can we use this to build our own resilience and build that hope?
Thanks, Deb.
I love that, Deb. And I'm fortunate enough to be in a business that is actually filled with hope, because, as I mentioned, for every one person who dies by suicide, there's 280 who think seriously about it, but don't kill themselves. We get to hear those stories all the time and be a part of those stories. Those are not the stories that people hear. They hear about the one person who died by suicide relative to the 280 who didn't. But we hear almost nothing but those other 280 stories. So we're constantly being fed stories of hope, and people say, look, I see nothing for myself in this life. And by the end of the call, they begin feeling and thinking differently. So I do happen to live in a world of hope. I'm very, very fortunate in that regard, and actually talk with people who survive suicide attempts routinely as advisors, because to me, they're the experts on suicide prevention. So they've taught me all about hope and meaningfulness. And one of the things that I've really carried with me through the stories that they've told me, and coming out of the most existential crisis one could imagine, is that when we're faced in times like these, where crisis is opportunity, when we're forced to take a different perspective and ask ourselves, as many of us are doing now, when you take so many things away from us, we have to ask ourselves, well, what's left? What do I have now for me that's meaningful? How can I build on that? And then when this is over, and we know eventually it will end, when it ends, we can ask ourselves now, how do I want things to be differently for me and perhaps even this world when it ends? And what can I do right now to start contributing towards that? So, again, these crisis moments are real opportunities for us to take stock and perspective in all that's meaningful.
Yes, absolutely. Well, thanks to both of you for being in conversation about these important issues and for taking time today to speak with me. And I've so appreciated this opportunity to talk with both of you about mental health, about suicide prevention, about hope. And I just want to thank you so much for that. And thanks to all of you who are able to join us from home online. And I hope you all enjoyed the discussion as much as we all did.